Hello everyone, my name is Steph and this is Bruce, our newest student paramedic. Good boy. Today we'll be discussing esophageal varices, one of many life-threatening emergencies that paramedics may be called out to. So Bruce, we'll start by breaking down what esophageal varices are, why and how they occur, some signs and symptoms, and then lastly we'll finish off by talking about how paramedics can manage this condition in the pre-hospital setting. So your first question, Bruce, is what exactly are esophageal varices? Well, to put it simply, they are veins in the esophagus that have become stretched and dilated with blood. The esophagus is this structure here in the thorax. The next thing we want to know is what causes esophageal varices. Well, the answer to that is high blood pressure in the liver, also known as portal hypertension. And what causes portal hypertension, you ask, Bruce? Well, the main cause of portal hypertension is cirrhosis, or scarring of the liver, which occurs in chronic liver disease. Some other causes could be a clot or a tumour in the liver. So you're still a bit confused and you want to know what causes cirrhosis and chronic liver disease? Well, there's a few things, including communicable diseases like hepatitis or various genetic and congenital diseases. There are also other factors such as chronic alcohol misuse or fatty liver disease, which can further be broken down into alcoholic fatty liver disease from excess alcohol consumption or non-alcoholic fatty liver disease caused by high sugar and fat consumption. Now that we know what causes esophageal varices, let's look at the signs and symptoms. So the unfortunate thing is that there are not many symptoms of esophageal varices until they rupture and bleed. So paying attention to the signs and symptoms of portal hypertension, which we remember is the thing that causes esophageal varices, is very important. Some of these include ascites, which is swelling of the abdomen, caput medusae, this is snake-like distended veins around the belly button, and personality changes or confusion due to hepatic encephalopathy. Now Bruce, make sure to keep these signs and symptoms in mind as we progress through this video so we can begin to understand what exactly causes them to happen. Now, however, if the varices are ruptured, signs and symptoms that we'll see is hematemesis, which is vomiting blood, and you definitely need those safety glasses, Bruce. We might see melena if the blood has been digested, which is black tarry stools. And lastly, signs and symptoms of hypovolemic shock, such as tachycardia, hypertension, altered or loss of consciousness, and pale, clammy skin. So Bruce, now that we have an understanding of esophageal varices, you want to dive deeper into the pathophysiology behind this condition? Well, in order to understand what happens when things go wrong in the body, we first need to understand how they function normally. So let's start by reviewing the normal physiology of liver circulation. In this diagram, we can see that the liver has two dedicated blood supplies. We've got oxygenated blood from the heart and deoxygenated blood from all of these other structures in the digestive system. The digestive system has absorbed nutrients, bacteria and toxins from the food and drink we ingest, and then this all makes its way to the liver to be processed here via the portal vein in here, coming into the liver. Once in the liver, this blood enters vessels called liver sinusoids, which are specialized leaky capillaries that allow substances to be exchanged into the liver cells, which are called hepatocytes, for processing. Blood then drains into the hepatic veins and then it returns through the inferior vena cava into the heart, ready for the next cycle. An important point to remember is that this is a very low pressure system, with the blood pressure in the portal vein sitting at about 4 to 5 millimeters of mercury. Now that we understand how things function under normal circumstances, we can look at what happens when things start to go wrong. So there are multiple steps that occur before we reach the point of developing esophageal varices. So step 1 here is damage or failure of the liver. This occurs due to those causes we discussed earlier, such as cirrhosis, where scar tissue and fibrotic lesions constrict the vessels within the liver, including those liver sinusoids. And in this area, pressure is now increasing due to this constriction. This leads us to step 2 in developing esophageal varices, which is portal hypertension. So as blood continues to back up into the portal vein, the pressure continues to increase above this 4 to 5 millimeters of mercury. And remember we said that the liver operates under very low pressures, so increasing this pressure can quickly become hypertension. As pressure continues to rise, blood is forced back into these various organs. Due to this, we will see increased hydrostatic pressure, which forces fluid out of the vessels into the interstitial space. Additionally, a damaged liver is unable to make enough albumin, which is a protein that helps to maintain oncotic pressure and keep fluid inside the blood vessels. So these two factors together result in lots of fluid shifting into the abdominal cavity, which explains why these patients may have ascites, another of the signs and symptoms we discussed earlier. So now moving on to step 3. We've had damage to the liver, we've developed portal hypertension. The body doesn't like this increased pressure in the liver because blood can't get through as easily. So the next thing that happens is that the body finds ways that the blood can completely bypass the liver so that it can maintain homeostasis. It does this by redirecting the blood through small naturally occurring vessels that connect the portal and systemic venous systems. In healthy individuals, these connections are tiny and carry almost no blood. However, when blood is redirected through these vessels, they become distended, and we call these collaterals. Some of the key areas that collaterals will form are in the esophagus, stomach, rectum, and umbilicus. For example, in the umbilical region, we will see another sign we discussed earlier, caput medusae, which is when these distended collaterals are seen radiating from the belly button in the shape of snakes. When collaterals form in the esophagus, however, we get the thing we've been talking about for this whole video, esophageal varices. So we've reached the final point. The esophageal varices have formed, so what now? And why is this something for us to consider as paramedics? Well, Bruce, the esophageal varices are extremely fragile and they're prone to rupturing. They can be ruptured by many things, including coughing, retching, vomiting, or straining. Alcohol binges, infections, or unmanaged renal impairment can also lead to rupture. And the really scary thing is, if they do rupture, they will bleed a lot. This is important because these patients can develop a life-threatening hemorrhage very quickly, and there is not a lot that can be done in the pre-hospital setting by paramedics. These patients really need priority transport to a suitable hospital that can perform the surgical procedures they require. However, there are measures that we can take in the pre-hospital setting when treating these patients. Primarily, we need to make sure to manage our ABCs. So let's go over these in order. Beginning with A for airway. Considering the location of the bleed, these patients are at high risk of aspiration, so we need to focus on airway management. A lot of suctioning will be required. Positioning of the patient is also important. We want to aim for a semi-recumbent position to help prevent aspiration, or a lateral position to allow for passive drainage. But this will depend on the patient presentation, consciousness level, and severity of the bleed. It is also important to consider that early advanced airway support may be required, such as intubation. Moving on to B for breathing. These patients will be losing a lot of blood, resulting in decreased oxygenation to the tissues. So we would normally want to administer high flow oxygen via a bag valve mask to maximize the oxygen saturation of the blood that they do still have in the body. In this situation, however, we need to consider that oxygen administration may be difficult if the patient is actively vomiting blood and requiring constant airway suctioning. In this situation, we may want to consider a nasal cannula, even though it will significantly limit the flow rate able to be administered. Moving on to C for circulation. With such significant blood loss, the patient can quickly reach a state of hypovolemic shock. Considering our lethal triad of acidosis, coagulopathy, and hypothermia, we know that these factors feed into each other and cause rapid deterioration. Catastrophic hemorrhage results in the loss of clotting factors in the blood, worsening coagulopathy. Oxygen delivery to tissues is decreased, and CO2 removal is impaired, resulting in acidosis. Managing these factors will be crucial for these patients to prevent rapid deterioration, and we can do this by careful fluid administration. While fluid can increase circulating blood volume, we know that it does not have the same oxygen carrying or clotting capacity as blood. Therefore, it won't be as effective at managing our acidosis or coagulopathy. What this patient really needs is blood products. These may be administered by paramedics if local guidelines permit, by retrieval or rescue teams, or within hospital. At this point, we also want to prioritise getting large bore IV access due to the high likelihood that these patients will require blood products. Moving on to D and E for disability and exposure. Going back to the lethal triad again and focusing on hypothermia, we know that low core body temperature can worsen coagulopathy by decreasing the efficacy of clotting factors, and it can also worsen acidosis by impairing oxygen delivery to tissues. Therefore, keeping these patients warm is another important consideration for paramedics to take. We should consider turning the heater on in the ambulance and using our thermal cap and blanket. In terms of medications, we may be able to consider TXA, or tranexamic acid, if local guidelines permit, and this will assist with clot formation and help to reduce bleeding. So Bruce, that was a brief overview of esophageal varices, their causes and their symptoms. We've had a look into the normal physiology of the liver and how complications can occur when things start functioning incorrectly. Lastly, we've also touched on how this life-threatening emergency can be managed by paramedics in the pre-hospital setting. To everyone watching at home, Bruce and I hope that this has been informative and has given you the confidence to know what to do next time you have a patient with esophageal varices. Thank you.